Mobile. And today I have the pleasure of sitting down with Dr. Gregory Rowe from Bigfoot and Ankle Institute in Gilbert, Arizona. Dr. Rowe graduated from the University of Utah in 2006, and he attended the New York College of Podiatric Medicine in New York City, New York, and graduated in 2011. He completed 3 years of foot and ankle reconstructive surgery, a surgical residency in upstate New York, where he was elected as chief resident during his third year. He was trained extensively in reconstructive foot, ankle, and leg surgical correction with emphasis in arthroscopic sports medicine, diabetic Charcot reconstruction, and traumatic injuries of the lower extremity. He was given the Top Surgeon Award from the American Foundation of Lower Extremity Surgery and Research in 2015. So after your fellowship was completed in 2015, he practiced podiatry with a group in northern New Mexico for a year and a half. And then he's worked hard towards your dream of opening your own practice. And you were able to do that in 2017, opening Bigfoot and Ankle Institute in Gilbert, Arizona. So I just wanted to welcome Dr. Rowe and taking time out of your day to sit down and answer a few questions about your practice and about older adults and all things that happens with their feet as they get older. So welcome.
Thank you.
So tell me, first of all, Bigfoot and Ankle. That's a very catchy name. Tell me where that name came from. I love it.
Well, when I took the practice over from another doctor in 2017, he did have a different name. I held on to that for a little while, and then wanted it to be kind of my own thing. And as I was talking with staff and everything else, we were kind of joking around, and that's kind of my personality. And so it just felt right, and we went forward with it. It puts a smile on people's faces. I've had patients come in and say, I have to meet you because I love the name. So that's how it came to pass.
And I will have to say, share this short story before I go on with the questions, is I've been practicing for about 14 years, and we met because we had a mutual patient. And I remember I had a question about some of her orders, and so I called your office, and your receptionist answered, and she said, you were busy seeing patients, and you'll get back to me. And initially, I was like expecting. Usually, when I call doctors' offices, they're like, "Okay, let me patch you through the MA or the nurse, and leave your message there, and they'll call you back." And so when she said, he'll get back to you, I was kind of like, okay, I guess I'm going to have to call later again and, get an answer. And I was surprised you called me back the next day, and I kind of forgot about it. And you had left me a message because we hadn't connected. And so I was like, oh, that's interesting. The doctor actually called me back, and it wasn't like his assistant. And I called back again, and I got your receptionist, and she was like, oh, he's with a patient, but he's almost done, and he'll call you back in a few minutes. So again, in my head, I'm like, okay, sure. And you called me back within, I think, like 5 or 10 minutes. And, we had the conversation we needed to about the patient. But I was really impressed by that. Because like I said, I've been doing this for a while, and very, very rarely will a physician, let alone a surgeon, call you back to answer questions on a patient that I want to know about, or asking, what can we do if we can do this? So I think that's very unique, and I think that says a lot about you and your practice, and how you treat your patients as well. And I got to also go and do some visits with my patient when she had follow-ups with you. And so, yeah, I will say that is not like many surgeons and physicians out there to do that. So.
Well, I appreciate the compliment. It's nice to just talk one-on-one with a physical therapist, because obviously I don't know anything, I don't know everything. And so it's nice to learn from physical therapy and just kind of their insights about what's going on with the patient. Sometimes I do miss stuff, and just kind of that kind of group team professionalism and working with the patient, the team approach works really well. A lot better for the patient.
Yeah, yeah. And like I said, when I had visits with the patient, you were very inclusive in, showing the x-rays and explaining it. Whereas again, I've sat in the room, and sometimes you're like the fly on the wall, and you just get acknowledged, and that's it. So I appreciate that. And like, again, I think it speaks volumes for who you are as a physician too, and how you care for your clients as well. So besides that, tell me how your practice is probably different than, a lot of people will go to a practice and there's like 5 or 7 different providers plus MA or plus PAs and so other practitioners there. What kind of separates Bigfoot and Ankle Institute?
I think a lot about what we talked about. I spend a lot of time, at least I try to the best of my ability, to talk to patients, educate them as much as possible. I feel like the more they know, the more confident they are in the treatment that they're getting, and the more compliant they are with following through on what's been recommended. Um, Especially, if we exhaust conservative treatment and we go down the surgical route. Um, that's a lot. There's a lot of anxiety that goes into that, and some uncertainties. Studies have shown that patients don't retain a high percentage of what they have talked to their doctor about.
Mhm.
And so just taking extra time repeating kind of what was talked about so that they're comfortable. Anxiety levels go down preoperatively when the patient actually understands more and can anticipate what's going to go on, instead of it just being all kind of a new surprise. And it's nice to have physical therapy available
Mhm.
just so that they know after the surgery what they're going to expect and that they're also in good hands.
Yeah, there's so many times that I'll have a patient go and see the doctor and they come back to me and I'm like, okay, so what did he say? And they're like, I don't know. It was so fast. And I'm like, did you ask the questions we talked about? Yeah, but I think he said this. And, they can't remember everything or they're so focused on one thing that that's all they remember. So yeah, it is nice that you spend that extra time with them. And even like the patient we shared, she raved about you. So that was awesome. Um, so, what made you go into podiatry? I mean, I know everyone specializes in so many things, but I feel like the last thing people think of is like feet. Why would you want to work with feet?
Well, I'd have to say I probably could have done a lot of different things and really enjoyed them. I think the biggest thing is the patient interaction. Just I enjoy helping people that come to you that just need it. I think the thing that pushed me towards podiatry was sports medicine. I was a exercise physiology major. Um, Enjoyed sports. I When I shadowed podiatrists, the sports medicine approach was really attractive. And then I got to find out I get to do surgery, and that was also exciting, right? And so, and then you kind of get through your training, and all of a sudden you figure out that you're good at this stuff, and it's something that you even put more of your time and energy into. And so, I would have to say, if I didn't see patients every day, I would be disappointed. I enjoy the interaction face to face, being involved in their lives, and being able to take care of them. That's very important.
Awesome. So, you specialize obviously in feet, podiatry, but within that realm, is there anything specific that you specialize in? I know you did a lot of your fellowship in the reconstructive surgery, but anything specific?
I would say anything below the knee. The one thing that I like about podiatry is that you can do, an ingrown toenail on a pediatric patient one day, and then you're doing an ankle fracture that night.
Yeah.
There's a lot of stuff that you get to do that's different. I It took great effort to make sure that I was trained really well so that I could do anything that came through the door.
Mhm.
Um, and so I, I would just say I put my heart and soul into everything that I do, from pediatrics to our older population, and then to the athletes in between. Um, I just enjoy it all.
Awesome. So we talked a little bit about working with physical therapy. Tell me kind of your stance on preventative medicine. Obviously, when people hear surgeons or they're going to see a doctor who's also a surgeon, they're fearful like, oh, he's just going to want to do surgery and that's all they want to do. But you're also big about preventative medicine or conservative treatments. So talk to me a little bit about that.
Um, so I feel like you really need to knock down these barriers in terms of like making sure that the patient understands what's available conservatively.
Mhm.
Um, I also don't want to waste patients' time if they feel like they've done everything. I don't want to lead them along. But most of the time, I would say about 90% of the time,
Mhm.
we want to make sure that we exhaust conservative treatment. As I continue to learn in my profession, I continue to find physical therapy even more helpful in certain pathologies,
Mhm.
um, incorporating them earlier on and making sure that we can do everything that we can to avoid having to do surgery. And then, unfortunately, if the pathology is there and it's just past a certain point, we would need to do that. But it's been very beneficial, and even my focus has changed to incorporate other providers to prevent that surgical occurrence if it's needed.
Now, there's a process of regenerative medicine. Speak to me about that and what a lot of people probably haven't heard what that is.
Regenerative medicine is a lot of the times we would use steroids, which would decrease inflammation and pain, and it would help the patient, but it wouldn't necessarily fix the problem or help the tissue or the joint to heal. There's been quite a few different avenues through amniotic tissue, PRP, which is platelet-rich plasma, and then bone marrow aspirate. These are three different ways that you can actually take things from the patient's body,
Mhm.
um, isolate something that can actually help them, and then inject it into the joint or the tissue that promotes additional growth factors, different types of collagen, anti-inflammatory factors that don't do anything but help the patient. We do have to be careful though if there's certain pathology that's gone past a certain point. It's not necessarily going to help. I'm very careful not to recommend something that's going to waste the patient's time or money.
Mhm.
And I try to give them a realistic outlook on regenerative medicine so that they don't become frustrated.
Now, PRPs, a lot of people that's, knows about that, and I feel like that's talked about a lot. Is that something you do in your office?
I do a lot of amniotic injection. I feel like that's coming from a different source. If the body itself isn't healing itself,
Mhm.
then maybe it's time to pull something from another source to optimize the healing. And each patient's a little bit different, age, pathology, and you kind of I take according to the pathology and the patient in a whole, and then make my recommendations from there.
Got it. Very cool. Yeah, there's a lot in that PRP. Like, I get a lot of questions with patients like, well, what about this? We've tried a cortisone injection, they've tried different, and they're doing therapy, and, they've always asked about that. And I know a lot of times that unfortunately isn't covered by insurances. Um, but the fact that you offer that as another source is great for patients. So let's kind of switch over to older adults. Obviously, that's who I love working with, and I specialize with working with them. And we do a lot, with their feet because of fall prevention. And a lot of times they can't feel the bottoms of their feet. They lose their sensation. But in your opinion, what do you, in your practice, what is the most common type of foot problem that you probably treat, probably non-surgically?
Non-surgically, I would say Achilles tendonitis, insertional Achilles tendonitis, where the Achilles tendon inserts right on the back of the heel bone. I would also say just general types of arthritis, wear and tear arthritis, patients that have rheumatoid arthritis as well,
Mm-hmm.
hammer toes, bunions, all of these things that we usually can treat conservatively or shoe modifications, activity modifications. My goal is through a team approach with physical therapy is to keep patients as active as they want to be,
Mm-hmm.
and that's essential. Bringing physical therapy into that as well, and then also making the recommendations from my end, and then physical therapy is the follow through at the end, and
Right.
to really kind of lay out the game plan and do a structured treatment plan where they can actually succeed in that and staying healthy and active.
Yeah, I see a lot of people with those hammer toes, and we try to do some heel raises, and they're like, I can't do it. My toes don't go flat anymore. And so they struggle with that. And then another population, I don't see a ton of these, but obviously diabetes is prevalent in this population. And I know you had in your bio, you did some diabetic Charcot reconstruction. So what do you do with people with diabetes and have issues, sensation issues with their feet?
So we need to keep just close tabs on these patients. The scary thing is sometimes they can have a joint reaction where their joint collapses in the midfoot or even in the rear foot. And so we want to make sure that we immobilize them as soon as possible if that happens. But preventative medicine, Medicare has approved diabetic shoes and inserts because they know it's preventative medicine. And we want to make sure that they're actually in the right shoe, that they have adequate offloading so that they don't have any hot spots on their feet. And also, we just want to make sure that if they do have an issue or a wound, that it's not going to persist and we can actually take care of that and get them healed so that they can do what they want to do.
Yeah, and footwear is like huge with these people.
It is.
It's a hard. They get comfortable in certain shoes, and trying to get them out of their sandals or flat, shoes without support um, is tough. But obviously, you would. I'm sure you would recommend some kind of more stable shoe for. I would think most of these older adults. A lot of times they have, like I said, these flat keds or sandals that don't provide much support for them. Um, and would you recommend anything for someone who just has general foot pain, or are you kind of want more individualized too with that?
No, I feel like Arizona's tough is just because a lot of it is recommendations for maybe an over-the-counter orthotic or a custom orthotic.
Hmm.
And if patients aren't going to wear them because they wear their flip-flops, then I've been able to get a bunch of good websites that patients can go onto and get a flip-flop or a sandal that actually has some sort of arch support, so they don't repeatedly have these issues, and at least they can get some support. So I try to compromise with my patients if I can't convince them on what's best for them, and do my best to prevent things that could happen.
Hmm.
But there are a variety of really good shoe and footwear options out there. Shoe companies really make their shoes according to the foot type you have. And so coming in and understanding the foot type that you have would be ideal. And then I walk them through a website to where they can actually pick the shoe that would be best for them. We size their feet, make sure the width is okay, the length is okay,
Right.
and just try to make sure that they really objectively see what they need to do.
I did have one question about toenail fungus. I actually saw a patient the other day and I was telling her about this interview. I'm like, do you have any questions? And so I didn't get this to you in advance, but she was curious about, she's like, well, what about the fungus in toenails or nails? And she's like, there was something she used to treat it, but she wanted to know, she says, when that comes, it can be really difficult to treat.
Yeah, so this is an interesting one is when patients come in and they feel like they have a fungal infection in their toenail,
Hmm.
I think standard of care is always biopsying the toenail, because you can get trauma to a nail, whether it's micro trauma, just repeated trauma to a toenail, or somebody dropped something on it, and it can become discolored and look like a fungal toenail. I always send it for a biopsy, just to make sure that I have a firm diagnosis prior to prescribing a medication that might affect their body, and I might need to get additional labs on. And so I don't want to just put them on something feeling like just because of what I saw, they have that. Because I've been surprised before, even though it looks like fungus, the lab is really the gold standard and it comes back with an objective finding.
Yeah, there was a medication that she says she takes that doesn't quite react with her, and but she takes it anyways because it works, and I'm like, oh, you probably shouldn't do that. But yeah, so that was kind of an issue, and I'm sure a lot of older adults deal with that probably more often than not. Would you say?
They do. Yeah, 60% of diabetic patients unfortunately have a fungal infection, because they're immunocompromised. And so they're unfortunately a little bit more of a target for that fungus to grow in their toenails. And the medication, oral medication, isn't always the best option for them, because it could affect the liver in 2% of healthy individuals, which is low, but still in a diabetic patient that's on multiple medications, it might not be the best option for them. So we can trim the toenails, we can do a topical antifungal, just depending on how the percentage of how much that toenail is infected. I try to educate them on and be realistic about what's really going to help, so they don't waste their time or money as well.
Right. And this may be a broad question, but just in general, for an older adult, as their feet ages and changes, what kind of advice would you give them?
So there are a lot of progressive, very slowly progressive deformities. Bunions form over time, hammer toes form over time. I would say continually sizing your feet for length and width to make sure that you're in the correct shoe. And then arthritis, unfortunately, happens to the majority of us, right? And so you don't necessarily have to live with your pain. If you come in and see us, we want you to be active. We want to keep you active. And we really will try to keep you as active as you want to be and treat you accordingly. But I would say just continual checkups. Don't let anything slip away, and don't ignore anything, because there are a lot of things you can do early on to make it so that it doesn't get worse.
Yeah, and I'm on a fall prevention coalition, and a lot of the tips or the fall risk are always your vision, weakness, home modification things, but you never really see feet. And it just kind of occurred to me as we were chatting that, we tell people like your vision, like go and get your vision checked because you need your vision to help you balance. But feet too. And like you were saying about how your feet can slowly start to change, I think a lot of people just take it for granted and choose not to go and see a podiatrist. And they kind of just feel like, well, it's part of aging. That's how my feet are going to be. But like you said, there's stuff that can be done if they notice that, right, to try to get in to see you or someone um, to figure out how to get that fixed or what can be done to help that.
Right. And so even if we do it like additional bracing, there's more nerve receptors in and above the ankle that can send signals to your brain that you're tipping or you're falling. It's just different things that we can do to help you to support patients, so maybe they don't have to go directly to the cane or the walker.
Mm-hmm.
If they feel more stable, then they're going to feel more confident, and then they're going to want to be more active. And then physical therapy is going to help them to do that.
Right, right. Um, any other suggestions or advice besides coming and seeing you older adults? Like I know I have one patient who they'll go and get their toenails trimmed, keeping good foot care in general as they get older. Any other suggestions or tips that they need to be aware of?
I would just say if something's been bothering you for a long time and you've been somewhere else, I mean, don't give up on it. Get a second opinion.
Mm-hmm.
I frequently will tell patients, even before surgeries, please get a second opinion, just so that you feel more confident with the procedures that have been selected.
Mm-hmm.
Go see somebody else, see if it's different, see if they explain it a little bit differently that you can understand it, or they might just find something that somebody else didn't find. And so, yeah, just letting it last is not the best option. And then, if you come in and see us, be ready for a good sense of humor,
Yes.
because we we like to have a good time here.
Yes, you do. And that is always kind of refreshing sometimes because doctors are just like in and out and on to the next patient. So that is
Right.
refreshing. Um, and you accept all insurances, major insurances, correct? To
All
practice?
major insurances, yeah. We do our best to make sure that we're contracted with your insurance,
Mhm.
so that there aren't any surprises. We check that insurance beforehand, and we get you in usually the same day, if not the next day. So we try to get you in as soon as possible.
Okay. Yeah. Like I said, it was great, going in and seeing your office. You're, I believe, like Pecos and Lindsay, correct, in Gilbert?
Correct. Yep.
Yeah. So, um, yeah, and my patient did great with you and had a great experience. And yeah, I just, like I said, I was very impressed with the care and the patient-centered care that you were able to provide, which at a lot of these bigger offices. Not to say that the doctor isn't great, but sometimes you lack that patient-centered care, and the time that you get to spend with the physician is rather quickly. So I'm always telling my patients, get your list of questions ready, and so you're set to go. But yeah, I appreciate you taking a little bit of time in your day to sit down and chat and talk about feet. Obviously, you love it and love working with people who have feet conditions. So yeah, thank you. And I will post your website, and obviously people can find you. You're on Facebook. Is there anywhere else that they can find you if they want to get in contact with you?
Yeah, please, if you're interested, I mean, on Google and on Yelp, you can read our reviews. I feel like we have really genuine reviews. Bigfootandankle.com, you can schedule an appointment online there. Or just call our office. We have receptionists that would love to talk to you. We don't have an answering system. They'll talk to you in the first pickup. I heard about that today from a patient. They loved it. So we try to make it as warm and as comfortable as possible.
Awesome. Yeah. So I will put all of that in comments below. And again, thank you, Dr. Rao, for spending your afternoon with us and early evening.
Thank you so much for having me. I appreciate it.
All right. Have a good night.
You too. Bye-bye.